All right, so thank you for coming today and happy Trans Day of Visibility. I'm really excited to introduce this training by the Washington State Society for Clinical Social Work. Today of all days during a very trying time for transgender people across our country. And I will just cover a little business quickly before we get started. This training is intended for educational purposes only and does not replace an independent professional judgment. Statements of fact and opinions are those of the individual participants and not the position of the Washington State Society of Social Work or its committees. The hosts of this training are sitting uninvited on the land of the Coast Salish people. In 1855, Chief Seattle signed a treaty with the US government, handing over 54,000 acres of land, and his tribe, the Duwamish, have yet to receive federal recognition. If you have your phone handy, the QR code on the left links to a website where you can make a donation to the Duwamish. The middle link is for a petition for federal recognition. And the right link is an essay about land acknowledgements by local comedian Howie Echohot. And I'll also share these links in the chat. Tonight's trainer is Leiyomi Preciado. And I just wanted to share a little bit about Leiyomi. I first saw her a year ago on a panel by the King County Recovery Coalition when she spoke on a panel supporting LGBTQ+ in recovery. Leiyomi is a natural storyteller and has a gift for teaching in a way that sneaks up on you and opens your heart. She is a peer counselor and a fundraiser for queer youth in Bremerton. And I can't wait to take my kids to her first performance, I believe next month, since the mandates have been lifted. She has more exciting adventures in the near future, so stay tuned for mid-May. And I can't wait to support her in those adventures. But for tonight, I invite you to listen to what she has to share on how to support people seeking gender-affirming care. And Leiyomi, I am ready to drive for you.
Awesome.
Take it away.
Thank you so much, Jenna.
You're welcome.
Good evening, everyone. First off, I just want to say I am truly honored and truly grateful that you guys took the time out of your day to be here. I know it's been a very long day, and the work that you guys do, not only in the jobs, but also the schoolwork that you do is very, very intensive, along with all of the other things that life throws at us. So again, thank you so much from the bottom of my heart for taking the initiative and finding, this knowledge and education that is desperately needed to help more people who do identify as trans. So again, my name is Leiyomi Preciado, she, they. I am a certified peer counselor, and I will be teaching and educating you guys about WPATH and what is required to write, hopefully, a letter to refer to gender-affirming care. And as we'll talk throughout this training as well, what you'll find out is that more often than not, the journey is not easy and it's not simple the first go around. So again, thank you so much for being here. And with that being said, we're just going to dive right into it. And just to give you a little background, we're going to spend about the first hour talking about all of this information. And then the last 30 minutes, you guys will have the opportunity to take all of these tools, skills, and education that you've learned within the past hour and putting it into practice. So I'm looking very forward to seeing how you guys absorb all this information and how you're able to utilize it to the best use that you guys can. So why do people seek care? Well, simple. The fact of the matter is that trans people have been around since the beginning of time. And it hasn't been until recently that, there's been more education, there's been more avenues to be able to share information and knowledge about what it means to be trans. Some of the first literary works ever recorded in human history that also included trans people, particularly Ovid's works, Metamorphosis, has stories like Iphis and Ianthe, Hermaphroditus, which is the first recorded, one of the first recorded characters that identify or is intersex, I should say. And then Aristophanes' creation myth of androgynos, which if you can tell right there from the root word, that's where we get the word androgyny. Next slide, please. So that's just a little bit of like setting the foundation to letting you guys know that, trans people are around. If you haven't met a trans person before, now you have, you can raise your hand. I'm a proud trans woman of color. I'm not ashamed of saying that. And along with that, the experience of being trans is really, really difficult. As a lot of you guys know who are in this field, there's a lot of stigmatization that has occurred due to the fact that just the history of psychology and how it originated is really one-sided, right? It really is. In this sense, it's suffice to say, cisgender people are writing the rules and the regulations that then affect trans people. So much so that there is the medicalization of gender. Dr. Hirschfeld of the famous German Institute of Sexology appealed to the eugenic side of the rationale to perform gender-confirming surgeries. He partnered with and went on to work with Nazis and perform forced sterilizations, which even now today in the modern world, there are some countries out there that do force and require sterilization to happen for a person to continue their transitioning into the gender that they identify with. In the 1930s and 50s, infants born in the US deemed inverts, another word for intersex, were forced to take hormone treatments and to undergo surgery. Public figures such as actress Christine Jorgensen, which she is pictured to the left, allowed their gender transition to be documented in the media, so much so that that became the standard of what it meant to be trans and what was deemed to be the correct way of transitioning. Reed Erickson, a white transgender male, and the founder of the Erickson Educational Foundation, funded research from the 60s to the 80s, strengthening the position of dominant institutional knowledge of, in transgender healthcare, AKA it was more focused on white trans people. And that's been the history of trans medicalization, is the fact that a lot of different trans people and their experiences and identities have been erased due to the fact that, quote unquote, they do not fit the standard of what a person deems to be whatever sex that they are transitioning into, which then further marginalizes BIPOC experiences and BIPOC transgender people who aren't seen as conventional and therefore are not eligible for care. Next slide, please. Which then leads us to further stigmatization through the DSM. So gender dysphoria was first introduced as transvestitism, which was included in the DSM-1 in 1952. Then as homosexuality was dropped and transsexualism was added in the DSM-3 in the 1980s, it became known as gender identity disorders. And as you can tell, anytime that something is deemed a disorder, people start to stigmatize and start to isolate populations and demographics from society, which then leads us to new diagnoses that suggest the maintenance of the status quo as a way to recoup losses and target new groups. One of the reasons why gender dysphoria was included in the DSM was because of the fact that insurance companies needed a way to bill for services. And that's where a lot of the stigmatization came from the fact that a lot of the wording when it was first introduced really made it seem as if transgender people were deviants. as they were the bottom of the barrel. And as such, a lot of the times, they didn't receive adequate care, were taken advantage of, and then reduced to not being human. Unfortunately, one of the biggest travesties in my eyes was the AIDS pandemic, which took away a lot of which would be now our elders. I just think sometimes to myself, where would we be as an LGBT community, T community, especially T community, because of the fact that a lot of trans people, trans women of color, put their lives on the line to be able to fight for the rights and the protections that we are currently afforded. And oftentimes we forget about that aspect of the trans movement, in so which that we're still discriminated against by our own community of LGBT brothers and sisters. So going back to the DSM, when the DSM-3 was revised and the DSM-4 came out, they started to phase out the term transsexualism due to, in part, that they started to recognize that it was really creating barriers to care. It was creating more stigmatization within society, and it was killing a lot of trans identifying people due to the fact that people, A, did not understand or were misinformed of what transgender, the transgender experiences and what gender dysphoria is in itself. However, again, trying to practice forgiveness, right? Due to, in large part, of the fact that we didn't have enough knowledge of what it meant to be transgender, transsexualism was still referred as gender identity disorder, with a small distinction between youth, adolescents, and adults. Yes, Sauzi, this presentation will be available afterwards. Thank you for asking. It wasn't until recently when the DSM-5 came out that, lo and behold, we were able to redefine and come up with a better term that really did not stigmatize trans people, and that is gender dysphoria. Gender identity disorder was replaced, and the current diagnosis of gender dysphoria was added when it came out. Thank you. Next slide, please. Yes, I know. And as there are other standards of care, there's also the international, there's an international committee for transgender healthcare, and also the ICD, I believe that's the name of it. They have different terminology, but they themselves have also aligned with the DSM-5. Well, I should say the DSM-5 has aligned with the ICD in stating that gender dysphoria is not a disorder, it's not the version of the stigmatization that we normally have when thinking about gender dysphoria. Again, the only way that this was able to be possible is that like-minded individuals, service providers, and people who were receiving services started to connect and really saw that there was a gap in terms of standards throughout transgender healthcare. So the standards of care are an authoritative guide to medical gender transition. They are written by a committee appointed by the World Professional Association for Transgender Health, aka WPATH. And WPATH is a big umbrella. Each region has their own. So here in the United States, we have US PATH, Canada has Canada PATH, UK has UK PATH. So there are different regionalized committees that come up and interpret the standards of care that WPATH then proceeds to publish. The first standards of care came out in 1979, and it was co-authored by Dr. Richard Green, who defined gender identity disorder in the DSM and centered mental health diagnosis and binary transition. What he stated was that the patient must consistently express the desire to change gender for 2 years while in relationship with a therapist, which back then I can only imagine. You know, it's hard as it is right now for people to tap into mental health services. I can only imagine how difficult it was for people back in the early 80s to even have that opportunity, let alone the quality of life and the finances to be able to receive the care that they desperately needed. Luckily, times have changed, and that really isn't a requirement as it stands. But within that, there are other parts that have been deemed best practices in making sure that the least possible harm is done to the individual. Versions 5 and version 6 of the standards of care were the first to refer to the moral responsibility to recommend hormone therapy and surgery. And no transgender clinicians were included in the writing of any of the SOCs, 1 through 6. Like I said, a lot of times in the beginning of transgender healthcare, cisgender people were the ones who authored, who wrote the rules and regulations. ICATH. That is a little bit different from WPATH. So yes, and just to let you know that there are we'll have another series. We're just going to briefly touch bases on just some generalized information, so that way we can get into like the nitty gritty and the meaty substance of what today's training is, and that's to hopefully encourage and empower you guys to learn and feel comfortable in writing referrals for gender affirming care. But thank you so much for that question. It wasn't until the most current version 8, that more trans-identifying individuals started to be a part of this process and sharing their own experience and knowledge, which also was the first one to be able to introduce as well informed consent and uplifting that notion that people are their own best experts. And oftentimes we need to be able to listen to what that individual, that person in front of us is telling us that they need and require to be happy, healthy, and safe. Version 8 as well, with more voices being brought on the table, it only just helps to further reduce gatekeeping and also stigmatization, because then different lenses and perceptions and points of views are able to create a bigger and better picture of what the experience that trans people go through, rather than just professionals and people who haven't had this experience, creating unforeseen barriers that then create a problem in the quality of care that a person is receiving. Thank you so much. So there's a lot of misconceptions as well of what gender dysphoria is and what gender nonconformity is. And I really want to take the time right now to help illuminate you guys, or help reinforce what you already know between the distinction of gender dysphoria and gender nonconforming. So gender dysphoria is the inherent distress caused by the incongruity between an individual's gender identity and sex assigned at birth. The distress is persistent, and other gender-affirming treatments are required, such as HRT, to alleviate stress. So what that means is that a lot of times the breathing techniques that we are first given will not work. Those other least restrictive or you know, the most common tools that we have in our repertoire to be able to help alleviate some of those symptoms of gender dysphoria distress, which would be stress, anger, anxiety, depression, right? Those skills and tools are not going to cut it. More interventions need to be added and included in a person's treatment to be able to, A, not only assist in giving them the care that they need, but B, preventing a person's life from vanishing off this world because of the fact that they don't believe that they belong here. And the reason why I bring that is because I do work with a lot of trans individuals who don't have the necessary resources or the opportunities to be able to tap into care. And when they do, a person who might not be as knowledgeable or educated in transgender healthcare may inadvertently create a barrier that causes a person to then think about solutions that they really shouldn't be thinking about. So I really want to hone in and focus on that as we go along through this training as well. The repercussions that we may or may not be aware of, due in part because of the fact that we just haven't had the opportunity to put these skills and tools and education into play, which is one of the reasons why I'm so grateful that 23 of us are here today and really taking the time and affirming that every single person that you encounter, regardless or irrespective of whether they're cisgender or trans, are treated equitably and are given and afforded the same opportunities as other people are. So what's the difference then to gender nonconformity? Well, gender nonconformity is when an individual's gender expression, identity, and role within a society differs from cultural norms or expectations. There's a lot of, a perfect example would be quote unquote a tomboy, right? A person who likes to dress more masculine, but it doesn't cause them a level of distress that they start to have other symptoms or might be experiencing minority stress due to, in fact, that they're not conforming to society's expectations, right? Gender dysphoria is the innate distress that a person feels inside that no matter what they do, you know, feel or say, they just do not relate to society's expectation of who they were born at birth to be, right? Gender nonconforming is the exploration of who you are as a person without the underlying stress, anxiety, anger that a transgender person might feel when they're going along through their own gender journey. And speaking of which, you know, there's a lot of different experiences within the transgender community. Just a quick raise of hands, how many people will work with Medicare, Medicaid? One? Hi, April. Two? Okay. Three? Awesome. So it seems we have a mixture. I myself work in community healthcare. So I work predominantly with people who have Medicare, Medicaid, and oftentimes intersectionality plays a huge role in their experience of being transgender. Not only are they trans, but oftentimes they also have other intersectional factors that come into play. They might be a person of color. They might be experiencing poverty, they might be experiencing homelessness, right? There might be different factors. And for those who are in private practice, you yourself might still meet with these individuals because oftentimes community healthcare and mental health centers are not properly resourced and don't have the appropriate people to be able to write letters. My organization in itself, we cannot write letters, even though we have people who are able and capable of doing it. So oftentimes we have to refer, I call them peers, you guys will call them clients, peers to like the Ingersoll Center in Seattle to be able to help connect them with appropriate service providers who are able to give them the letter affirming that they do need these gender affirming treatments. So when thinking about intersectionality and opportunity, I really want you to think of like, where are you employed, right? Are you private or are you a nonprofit, Medicare, Medicaid? Because that's going to impact, right, your interactions with specific groups of trans people and the demographics. I have the privilege that I have a full-time job and I have private health care and I make pretty good money where I can go to a private practice and receive services and pay for the letter. However, my other trans brothers and sisters who are currently living on the streets, who are just thinking about surviving through that hour, through that minute, through that day, they don't have those kind of resources. So when they do contact the Ingersoll Center, for example, and they give them a list of providers, but then the providers have requirements as, oh, I need to meet you twice, and each meeting is $250, right? And this individual lives in Tacoma, and they have to make it to Seattle, and they have no money. How is that impacting the quality of care that they're receiving? How are you unknowingly creating potentially barriers to a person's wellness? And I'm not going to say one way or the other, because that's more of an ethical question that you should answer for yourself when you start thinking about these kind of things, right? If you do need to charge for a letter, just be mindful that, yes, if you do work on private practice, you might get a person, but that person might have been referred from a different organization and they may not have money. How is that preventing them from accessing care? And how is that further stigmatizing and isolating them from society? Right? Just because society tells us to do things one way doesn't mean that you have to go along with the status quo, because as we've seen, the status quo hasn't worked. And I know that each and every single one of us are in this job, in this field for one reason or another. And I really want to highlight that and remind you, right? Our duty that we have to the people that we are providing services for. Just a quick stat that I'm going to throw out there just to put the gravity of the situation. The average life expectancy for a trans woman is 35. The average life expectancy for a trans woman of color, 32. I'm turning 31 in 2 months. And I'm lucky enough where I have a job, I'm accepted by society because I'm passing, where I am able to tap into these services and receive the gender affirming care that I need to be 100% me. Other people that you might interact and might be providing services, they may not have that opportunity. And you might be the avenue, you might be the key for them to survive and thrive by affirming who they are as people, first and foremost. By honoring that they are their own best experts. Because let me tell you, being trans is not easy. It's not easy whatsoever. And sometimes having to jump through all these hoops on top of already the experience that a person is going through, which may include sex work, police brutality. It's tough. With that being said, like I said, in terms of thinking about who we are providing services to, if you are working with Medicare and Medicaid, I'll get to you in a second, Kayla, I see you. Thank you so much. If you are providing services to a peer who has Medicare or Medicaid, there's only one doctor in the state that accepts Medicare and Medicaid for gender affirming surgeries, both top and bottom, and that's Dr. Stellar in Spokane. The only surgeon. Fortunately, UW is going to be hiring and getting more trans-friendly providers. So there are going to be more providers in the state of Washington and on the western side. But for right now, Dr. Stiller in Spokane is the only provider that accepts Medicare and Medicaid for gender-affirming surgeries, gender-affirming care. And his waiting list is anywhere from, last that I spoke to an individual, anywhere from 8 to 12 months. Be aware of any undue barriers that you may be creating if you're charging for referral letters, like I stated previously, or creating parameters that exclude portions of the trans experience. Collaborative trauma-informed care will always be key to insisting people on their journey and center on informed care and personal choice. Because ultimately, they're their own best experts. Acknowledge the Eurocentric view of Western medicine and its history of dictating gender expectations and perceptions of beauty. And the reason why I bring that up is just like we stated previously, when Christine Jorgensen was so open with their own transition, it kind of created this unattainable standard of beauty and what it means to be trans. So when we think about that, you know, there are other extensive cultures throughout the world that have had a very thriving history of accepting gender nonconforming and trans individuals. And it wasn't until recently, the turn of, you know, the millennia, where unfortunately colonization has happened and it has erased a lot of that culture that previously had accepted that portion of society. Some cases being India or New Zealand, or even here in the United States with the very sacred and honor to spirit, right? There's extensive history of non-Western civilizations who have honored and respected and saw trans individuals as shamans and healers and people who were able to connect the spiritual and the physical world with one another. So when thinking about giving services to a person of color who might be trans, right, take into that consideration that maybe their culture has been affirming. However, due to the fact that they're here in a Western civilization, what kind of impact that may be having to their own perception of who they are as a person. And what perception and bias may you unconsciously have within yourself in which you may be preventing them from accessing that services because they don't fit those parameters. Just a little bit to think about, right? When thinking about giving appropriate care and doing no harm in our practice, in our work, thinking about those things really will illuminate how to best walk alongside your client, your peer. Next slide, please. So Ms. Jenna, would you like to assist me here?
Why, of course. Well, let's see. The practices that I have gleaned from, I'm still just a student and am learning a lot, but last quarter we had a visiting instructor, Flynn Alexander from Michigan, and they introduced me to the Gallup. And so I've put together just a few. These ones spoke to me the most for affirming and harming practices. So examples of affirming someone would be using the client's words for how they describe their gender and using their pronouns. Acknowledging your privilege and how it might impact the client. And I think Leiyomi just went over that beautifully. Asking if the client needs any resources or referrals. And I think that this is also kind of a response to the earlier standards of care where where providers were told they had a moral responsibility to recommend care. And so, you know, we don't know what someone needs until they tell us. understanding how not everybody fits into the transnormative narrative, and what I learned about transnormativity will be in our reference slide. Really wonderful research by, I think it's D. Riggs, and it goes along with a lot of that what we're learning tonight. And then harming practices would just be, digging into someone's gender history, quote unquote, how someone presented in their childhood, or when they went through puberty, or when they were in college, digging for some reasons as to why someone is transgender is very harmful. Assuming that it is rooted in childhood trauma, or even rooted in sexuality. A really common one in queer communities is to just say, you're just a butch lesbian, or what have you. That's not it. And assuming that all concerns that someone has relate to gender identity or dysphoria. Requiring a mental health assessment of all clients seeking medical transition. This would be, more a note for doctors and nurses in the room to consider whether or not, your practices can be informed consent models. And then for the mental health professionals, refusing to write a letter because family, friends, and coworkers aren't supportive. Again, there's so much stigma in our society that it's really hard to escape it, no matter how close people are to us, or to your friends that you're trying to help. So thank you, Leiyomi. And I believe someone had a question.
Yes. Kayla, if I'm not mistaken.
Okay. Go ahead and unmute. I think you can unmute yourself.
That might be me, but I just didn't lower my hand. Sorry.
No, you're all good. You're all good. Perfect. So one of the things that I do want to talk briefly, just and it concerns with that, is I've worked with a lot of older trans individuals who, time and time again, I've heard stories of them trying to access gender affirming care back in the 80s and the 90s. And one service provider or the other told them a similar statement of, oh, you're not going to make a pretty woman. Or, oh, you're not going to, hormones are not going to make you beautiful, or something along the lines, right? And again, that really reinforces the fact that we have to be really mindful with our own biases that we have, right? Because it's not our journey, it's not our perception of who they need to be, or our expectations of how they need to conform in terms of role, appearance, or any of that, right? Our role there is to support and provide an avenue for them to access care. So just, again, just be very mindful that language is important and it's powerful. And a lot of times people who are already in a state of distress are going to be hyper aware of what we say. And that may impact the relationship that you may or may not be able to have with that person, because of creating, again, undue barriers with our words, or with our perceptions or expectations. Next slide, please. Perfect. Yay. So now we're going to get to the nitty gritty. This is what you guys all came here for, right? Is how to write a letter. What does it mean? What needs to be in this letter? Before we get there, yes. Before we get there, we're going to just give you a brief overview of WPATH, what it covers. So in front of you in the screen, you're going to see version 7, and it has you read correctly 69 pages in this WPATH version. The newer version that will be coming out hopefully sometime this spring. Thank you, Sazi. Will be formatted a little bit different, and there will also be some new added topics, which would include education, ethics, Unix, non-binary, sexual health, and then the other topics will remain the same. Next slide, please. Okay, so treatment for gender dysphoria. Some ways that people who experience gender dysphoria can affirm gender is by receiving psychological and medical treatment, such as living in a desired gender by changing gender expression and role. Relatively, I shouldn't say easy, but probably the quickest way for a person to explore their gender. They can also start hormone replacement therapy, HRT, which may include anti-androgens, and introducing either testosterone or estradiol at later stages. After that, if they still continue to be experiencing gender dysphoria and need further gender-affirming care, gender-affirming surgery such as facial masculinization, feminization, top and/or bottom surgery would be other courses of treatment that a transgender individual may receive. Receiving psychotherapy to better equip and assist in overcoming minority stress, increase self-worth, foster healthy relationships, reinforce resiliency, positive coping skills, and teach boundaries. I think that's one of the biggest ones, teaching boundaries, could be other treatment options for a person who is experiencing gender dysphoria. Next slide, please. So we're going to take a break because I know that we've gone through a lot, and it's a lot, right? It's a lot. And I don't expect you guys to absorb everything right here and right now. And that's why we will be offering another follow-up course later on if you guys have further questions after this training that you guys really want to dig deeper into. But for right now, I want you guys to take some time, about a minute or two, and try answering this question. What are other ways that trans people can alleviate gender dysphoria and affirm gender identity? And you can either raise your hand or you can write in the chat, whatever you're more comfortable with. Yes, April.
Unmute. I was thinking that it probably really makes a difference to find community, right? I would think so, and to be around people who understand. Without that, maybe they have a shared experience with minority stress, maybe not, but they're going to understand transness. That's my input.
Yeah, no, thank you. Absolutely. And one of the things that I thank you for bringing it up is, irrespective of whether a person is white or a person of color and trans, just the fact of being trans, they're going to experience minority stress, right? They might not express it. They might not experience, I should not say express it, experience it to such a degree and level as a person of color, but just due to the fact that they're not conforming with societal expectations, they will have stress introduced into their lives. So yes, thank you so much for that, April. And then for the people who wrote on the board, being accepted, yes. Connecting with community that is supportive, absolutely. Spending time with people who's, community and decolonizing practices, perfect, Sazi. Support groups of people also going through gender journey, absolutely. You guys are absolutely right, absolutely right. Am I saying that correctly?
Yes, I was just going to add that for a lot of folks who sometimes they don't have like a wide community of people that are safe to have their chosen name or pronouns, but encouraging them to find, even if there's just one safe person in their life, that they get to have like consistently and lovingly and just compassionately using their name and pronouns in a way that feels safe for them, even if in other aspects of their life that's not an option.
Thank you so much. Absolutely. And you know what? Sometimes, depending on what kind of services you'll be providing to that individual, whether long term or short term, right? You might actually be that safe space for them, right? Until they're able to build that community, that family, that chosen family, that support system. You yourself may be that safe space, right? And that's what's really important, just like Anne was bringing in, is the fact that you yourself could be that person for them until they are able to learn the required skills and tools necessary to have that happy, thriving, successful relationship with other people, with community, with parents, with siblings, right? Or in the East Coast, you know, anyone who's seen Pose, houses that they have out there in the East Coast, the chosen family, people that have been isolated or have been ostracized from their families, and they create family within each other, right? It could be various things, but I think that, again, you might be that one person that has been that first person to acknowledge and see them for the human that they are, right? And be that safe space where they're able to share all of these deep, dark thoughts that they've been having because of the fact that they are experiencing the trans experience, right? Am, do you have another?
No, I think I just forgot to.
No worries, it's all good.
I have to click lower hand. Okay.
Absolutely. One misconception that I also want to bring up is the fact, I think I touched upon this previously, is that just because trans people are in the LGBT community doesn't necessarily mean that it's a safe space for that trans person. There is transphobia, and oftentimes the transphobia that I've experienced has come within my own community, which is like shocking, right? You're like, oh, peace, love, rainbows, unicorns, yay. And I wish that were the case, right? But it's not. It really isn't. And that's the saddest part, is, you know, the fact that we have brothers and sisters who are walking a similar journey as us, and yet society has infiltrated so deeply that they then project and persecute the own community that they're a part of. So just being mindful and aware of that sometimes when we encourage a person to go to an LGBT group and they're trans, it might not always be the safest place for them. Thank you everyone who gave their answers there. I truly appreciate it. You guys were all right. All right. Community and support are instrumental and paramount in being able to make it, right? And being able to live the life that that person desperately wants and desires and deserves. Next slide, please. So there is a distinction between youth, adolescents, and adults, right? I want to put a caveat here. You know, when I say that there is not enough data out there, it's the fact that there isn't enough data specifically for transgender people, right? A lot of the studies that we have extrapolated and base our medical treatment in terms of like HRT are based off of cisgendered people and the interactions and the reactions that they have. There is more studies and data coming out, but as it stands, you know, oftentimes the younger generation are the secondary pioneers of transgender healthcare as new treatment becomes available, right? We don't know the long-term repercussions of these treatments. There's no other way to put it. But what I do know is that not having these treatments available at all is not an option, right? I joke with my doctor, and my doctor actually told me, you know, hey, you're my first trans client that a trans patient that I'll be working with. You're going to be my guinea pig. And I'm like, you know what? Because we still don't know, right? Current studies show that from children who experience gender dysphoria at an early age, only between 6 to 23% continue to exhibit gender dysphoria as they grow older. And that's why I state that there's not enough data out there, right? Because to me, 6 to 23% is a huge range when it comes to statistics, right? So we still can do better in getting data to be able to create better outcomes for people who identify as trans. Gender dysphoria usually disappears by or around puberty for most kids experiencing gender dysphoria, per current studies, right? Who knows if that will change as more data becomes available, but currently that is what we have. Experiencing gender dysphoria as an adolescent is a more reliable indicator of continuing to experience gender dysphoria as an adult. And when I talk about adolescents, I'm talking about predominantly kids from ages 11 up. Yes, Sazi. So for children under the age of 11, that's where the data comes from, in which if they're experiencing gender dysphoria at an age under 11, you know, they only between 6 to 23% continue to exhibit gender dysphoria as they grow older. Once they hit 11 years old, and it's still there, it's still present, then that's a higher likelihood that they're still going to be experiencing that as an adult. Next slide, please. No worries. So there are different types of physical interventions, right? And I think that it behooves us for us to be able to be honest with our peers when talking about some of the treatments that they can potentially access, right? There's the fully reversible interventions, such as using puberty suppression medications, just like GnRH, and other oral contraceptives like progestin, spironolactone, etc., to prevent onset physical changes of puberty and suppress production of estrogen and testosterone. So what this means is, for example, if a kiddo states that they're experiencing, or they're giving indications that they're experiencing gender dysphoria, and parents or a kiddo, still don't know for sure, but they know that they don't want to get those secondary characteristics that happen with the onset of puberty, they may decide to explore getting puberty suppression medication, which puts a pause button on puberty, right? If that kiddo then at a later age decides that they aren't experiencing gender dysphoria, they aren't trans, and they may be gender nonconforming, however, at that point, they can stop taking the puberty suppression medications, and Mother Nature will do what it does naturally and put that individual through puberty, right? Other types of interventions are partially reversible, hormone replacement therapy. So if a person is prescribed and given testosterone or estradiol, some physical changes like the deepening of the voice due to testosterone is not reversible, right? Breast growth, gynecomastia, for male to female trans individuals, it's not reversible. So these are some considerations that you might want to explore with your peer or your client, I should say, when talking about receiving gender-affirming care and the letters that they'll need to be able to access those treatments. I will state with hormone replacement therapy, it is a treatment that a person can do ICAT, right? Informed consent, and can start receiving as an adult without needing or requiring a letter, right? One of the other things that I also want to bring up into consideration is the fact that hormone replacement therapy can affect fertility. So that's one thing that, you know, you might want to explore with your client as well, is what are your ideals, or are you looking to have children, right? Because oftentimes some people, you know, are so desperate or really do need to have that gender affirming treatment right there and then they're not able to see all of the other ways that it might affect other parts of their goals or dreams if that's a part of them, right? So just doing due diligence and laying out all of the options, all of the outcomes to that individual so they can make the best informed decision that they can make. Again, it's going to be very beneficial in not only creating a sense of safety, but also a sense of trust, right? And then finally, the other intervention is irreversible, and that's any gender affirming surgery, top or bottom, masculinization or feminization, so on and so forth. Thank you. So for kiddos specifically, what are the criteria for puberty blockers? In order for adolescents to receive puberty suppressing hormones, the following minimum criteria must be met. The adolescent has demonstrated a long-lasting and intense pattern of gender nonconformity or gender dysphoria, whether suppressed or expressed. 2, gender dysphoria emerged or worsened with the onset of puberty. So that's why the age of 11 is typically used as an indicator of like, oh, you're still experiencing gender dysphoria, you have a higher likelihood of continuing to experience gender dysphoria as an adult, right? Any coexisting psychological, medical, social problems that could interfere with treatment that may compromise treatment adherence have to be addressed, such as that the adolescent situation and function are stable enough to start treatment. 4, the adolescent has given informed consent, and particularly when the adolescent has not reached the age of medical consent, the parent or other caretakers or guardians have consented to the treatment, are involved in supporting the adolescent throughout the treatment process. Next slide, please. Now, in terms of hormone replacement therapy, it's a little bit different depending on whether you're an adult or if you're a kiddo, if you're a youth. Youth cannot access hormone replacement therapy unless they also have the permission of said parent, guardian, or caretaker. So I'm just going to put that out there. They can access puberty blockers at a younger age with parent consent as well, but they cannot whatsoever tap into or access hormone replacement therapy unless they have the consent of a parent or guardian as well. The recommended content of a referral letter for feminizing or masculinizing hormone therapy is as follows. The client's general identifying characteristics. So now we're going into the actual writing of a letter, what a letter needs, right? So it needs to have the client's general identifying characteristics. So if they go by she, they, and they were male assigned at birth, make sure that you put in that, referring to their gender. Absolutely, thank you so much, Am. So yes, here in the state of Washington, mental health consent is 13 and medical consent is also 13. However, for gender affirming surgeries, they have to be of adult age of 18. They cannot receive any type of surgeries until their age of 18. They can tap into other gender affirming treatment, like I stated before, puberty blockers and hormone replacement therapy, but that has to be with the consent of a parent. And youth under the age of 11 will not be given hormone replacement therapy because they're just too young. The only option available for them is puberty suppressors. So just to clarify, because I think that there's a lot of misinformation out there right now, currently in the news, of what trans kids can and can't actually access in terms of gender affirming care. Then the third point, the duration of the referring health professional relationship with the client, including the type of evaluation, therapy, or counseling to date. 4, an explanation that the criteria for hormone therapy have been met, and a brief description of clinical rationale for supporting the client's request for hormone therapy. 5, a statement that informed consent has been obtained from the patient. And 6, a statement that referring health professional is available for coordination of care and welcomes a phone call to establish this. For providers working within a multidisciplinary specialty team, a letter may not be necessary. Rather, the assessment and recommendation can be documented in a patient's chart. So more often than not, if you are going to be writing a letter or referral for hormone replacement therapy, it's probably going to be for a kiddo, right? And I'm not going to get too much into the legalities of that, but that is something that you will have to weigh in terms of honoring whether or not they want to share that piece of information with their parents, right? That is something that you guys will have to make the decision. And again, there is going to be another course on ethics and the legality of all of this as well. So if you have further questions, I definitely encourage you to sign up for the second session that we'll be having in the future. But yes, that is kind of like the tricky part, and I'm not going to get into it because I don't get paid enough money to do that. So what I would state to simplify this whole spiel is having the person's, their name, their pronouns, what kind of diagnoses they currently have, if they have co-occurring, for example, depression or any other sort of mental health issue, include that. Number 3, the duration or relationship, depending on whether it's a long-term client or if it's someone that you're just going to be meeting once or twice to be writing a letter. You can include that. I've seen some letters that don't include it and the letters have been accepted. I've seen other letters that they do need it. It honestly depends on the insurance company and what they require. So, and then an explanation of the criteria for hormone therapy. So like, what have they already done and what has worked and what hasn't worked, right? A lot of times kickbacks will happen from insurance companies because they want to know what has already been tried, right? Because unfortunately, they're a business and they're looking to cut costs, right? So being able to do that heavy lifting and legwork for your client that you will be assisting and stating, look, this is what so on and so forth has already tried and hasn't not worked, and they're still experiencing gender dysphoria and depression and isolation and anxiety and all that stuff, there's going to be a higher likelihood of that letter referral being accepted the first time, rather than your client coming back to you and stating, hey, the insurance company just wants to know what I've already done. So just keep that in mind. And of course, having that statement that the client does know specifically the pros and cons, I shouldn't say the pros and cons, but the outcomes that could potentially happen as they are accessing care. And then of course, just always allowing yourself to be open for further coordination will make things a lot smoother for everyone. Trust me. Next slide, please. So risk of preventing gender-affirming care. For any individual, the level of distress from experiencing gender dysphoria varies greatly. For me, my gender dysphoria is not so high where I need to be presenting like this. Jenna can vouch. A lot of times I look like Oscar the Grinch, sweatpants and a long t-shirt and I'm good. So it honestly varies, right? Some people really experience gender dysphoria deeply and they desperately need these treatments like yesterday, right? And some other people are comfortable enough or they've been able to learn how to deal with the stress and the situation of being trans, where they're like, you know what, I'm looking more to explore a little bit more and making sure that I'm making the right decision. I don't need this right now, but thank you for offering, right? For youth and adolescents, refusing appropriate and adequate care can increase likelihood of experiencing other co-occurring mental health and or substance use issues, which exacerbate feelings of hopelessness. Who would have thunk? 82% of trans individuals indicate that they have considered killing themselves. and 40% have actually attempted, per data cited by the National Institutes of Health. That's alarming, right? For kiddos who are receiving gender-affirming care and whose identity is affirmed, the suicidal ideation drops by 60%, right? That's a huge decrease. We'll get there, Adelina. Thanks for asking. Like I said, once receiving gender-affirming care, a study done by the Trevor Project showed a 60 to 73% reduction in suicidal ideation. The way to combat this, Adelina, is you just being the best human being that you can possibly be, and being able to respect and honor a person's identity and walking alongside their journey, right? Being able to meet a individual and giving in collaboration, writing a letter is an absolute way that we can prevent this from happening. And advocating for said individuals, right? Oftentimes they don't have people on their side to help advocate. And even I myself have experienced transphobia in healthcare settings, and I could only imagine other individuals who don't feel empowered of how mistreated they become. So a lot of times, right, the way to overcome all of these negative outcomes is to be able to give the appropriate care without creating those boundaries or barriers that systems create, unfortunately. One of the experiences that a lot of trans people go through is sex work, right? And then they go into the criminal system. I don't even call it a justice system, it's a criminal system, right? And if they were to have received that support or access to these resources, who knows if that could have been prevented, right? Remembering to do no harm. I think that's paramount, is remembering to do no harm, right? Next slide, please. We're almost done, y'all. I know. Special considerations, which we already touched briefly upon. Adolescents in Washington State have medical rights at the age of 13 and can ask for parents not to be involved in certain processes, right? Adolescents do not have avenues to pursue hormone replacement treatment or surgical treatment without guardian consent until the age of 18. Right? So there are some treatments that adolescents and youth can tap into, but the big, scary, big bad wolf that the news and the media try to portray it as, that's not true, right? There's no actual surgical treatment that's done until that youth has reached legal adult age of 18. Next slide, please. The letter, woo! Yay! So just reiteration of what surgeons and insurance are looking for. Again, identifying characteristics, any psychosocial assessments, including diagnosis. Like I said, you don't have to put the duration of the relationship with the client. If you've been working with said client for, 6+ months, then that would be a positive to put there, like, hey, I've been working with this individual for the past 2 years. And yes, they are experiencing gender dysphoria. Explanation for the criteria for the surgery that have been met. Again, listing everything that's already been attempted, right? And why this next treatment is necessary. It's going to be really instrumental in having that letter approved by the surgeons and the insurance. And a statement about the informed consent that has been obtained from the patient/client. And again, just a little sentence or blurb with your information, stating that you're open to coordinate and collaborate with further treatment and care. Thank you, Jenna. Next slide, please. Okay, so there is a difference, male to female, female to male, depending on the individual and their journey. Insurance providers and surgeons can require additional referrals. Some insurance and or surgeons will require the individual must have lived at least 1 year in gender role before providing gender-affirming surgeries. It all depends. Depending on the insurance provider, they might ask for 1, 2. It honestly depends. But I will state this, that to receive top surgery, 1 letter will always be required, and to receive bottom surgery, 2 letters will always be required. In most cases, adults will not need a referral to initiate hormone replacement therapy. They will work with their PCP or Planned Parenthood with informed consent. And again, not all experiences are similar, and not all service providers are equipped or have current knowledge about transgender healthcare. Gatekeeping is very common. Next slide, please. And here we are, top versus bottom referrals. Like I stated, 1 referral from a qualified mental health professional is needed for breast or chest surgery, so mastectomy, chest reconstruction, or augmentation mammoplasty. And then 2 referrals are required from a qualified mental health professional who has independently assessed the patient/client, are needed for genital surgery, hysterectomy, salpingo, oophorectomy, or orchiectomy, genital reconstructive surgeries. If the first referral is from a patient psychotherapist, the second referral should be from a person who has only had an evaluative role with the patient. 2 separate letters or 1 letter signed by both, if practicing within the same clinic, may be sent. Each referral letter, however, is expected to cover the same topics in the areas outlined, right? So both referrals will have the same information to validate and reinforce. Yes. Next slide, please. We finally made it, y'all. Yay! So I know it's a lot, and I know that we might have gone really quick. So that's why we're going to take the next about 15 to 18 minutes to give you guys the opportunity to go into smaller groups. We have a case study on Hallie S. You'll have a facilitator, either myself, Jenna, Salome, or Danielle. We will be helping you guys all do this practice. So Miss Jenna, could you please divide us into groups? Thank you guys so much for being here. We got a lot of great questions. If you guys want to stay and talk a little bit more, I'll still be on. But I do want to be mindful of everyone's time. I know you guys have friends, family, loved ones, responsibilities. It's a Thursday, so still a work day. So if you guys need to leave, thank you so much for being here. If you have any further questions, please reach out to Jenna. You can scan that QR link code. My email, you can always email me questions at my name, leiyomipreciado@gmail.com. And if you have any follow-up questions that you want to answer just one-on-one or have a conversation, I'm free, available at your convenience. So just let me know. But if you're willing to stick around for a little bit, or you have any other questions, comments, and concerns? Yes.
In our group, we had such a rich discussion centered around the phrasing of the substance use portion. And we would love to hear your input, your insight of what would be the best way to phrase it.
Yeah, absolutely. Thank you so much for asking that question. And actually, Sazi asked the same question in our group. And it all comes down to, you know, again, doing no harm or doing the least harm, right? My question to you all is, what generally ends up happening with a person who is experiencing substance use and are then able to utilize and practice positive coping skills and gain a positive support system? Does anyone want to answer that? What generally ends up happening to the substance use?
I would think that it would at least, if not totally stop. I mean, they might be using substances to self-medicate because of the pain of not being able to access gender-affirming care. I think it would improve.
Thank you, April. Yeah. Anyone else? Yep. That's it. It's not rocket science, right? It really comes down to the fact that, you know, substance use in the trans community, I used substances when I was experiencing homelessness, right? For me, my substance use was weed and dabs especially, like that one dab and then I was gone, right? And I didn't have to feel the pain, and I didn't have to feel the shame and the embarrassment that I felt within myself. And I thought I had no one, right? I had no one. So what else was I able to do? You know, do drugs with and forget about it, right? Because I was so hopeless at that time. It wasn't until I started tapping into resources and I was starting to get therapy and I started to reconnect with my support system, which I had isolated and self-sabotaged myself from, right? My substance use started to go away. So when thinking about that with an individual, we have to look at who is receiving this letter, right? Who is receiving this letter? Insurance companies and surgeons, right? And if you write on that letter, for example, and you state that substance use is present, will that create a barrier to care? Are you creating a barrier to actually resolving the root cause and the root issue of why said person is experiencing what they're experiencing or using the substances that they're using? Right? So being mindful of that, you know, substance use, yes, again, society dictates that we should look at substance use in a particular way. And I challenge you, right, to expand your own perception of substance use and recognizing that if we were to affirm a person's identity, that may help alleviate some of the causes that is preventing a person from living a healthy life without the uses of substances. So I saw Am first, and then I saw Megan. You are muted.
Thanks. One of the things that came up in our group, well, a number of things, but one of them was like, we're all individual clinicians writing on behalf of our own licenses. And so from the get, like if we didn't feel like this person had, you know, has adequate informed consent, we wouldn't be writing the letter to begin with. Therefore, like because of that, inherently the substance abuse concerns don't rise to the level of concern that we would think it should impact their ability to receive care. And we all sort of agreed that like less information for insurance companies in general is probably better on behalf of our clients. And so we were just wondering, and maybe this is a question that we bring to the next training about the ethics and legalities of everything. But I mean, I'm specifically wondering, like, do we know if the wording in the clinical kind of summary, which was used, is substance abuse is present and below threshold for concern, is that wording adequate for a letter that's actually being submitted to just simply say like it's present and below threshold for concern? Because I've done letters where, and I usually do include like a little blurb about substance use, and usually it's like, just say like, it's not, you know, there or whatever. But if we do know it's there, but we're trying to not create an issue where it doesn't need to be, is that adequate?
Yeah, absolutely. What does your gut tell you?
My gut tells me that I would put it in. And then I would, if I got contacted, I would just deal with it then. Like my gut tells me that if I'm willing to write the letter, I don't think it's an issue enough to create a barrier for this person.
Yeah, absolutely. I think that if you are, yeah, you're absolutely right. If you feel comfortable and you can speak up for it and you know, really own it, then go for it, right?
Yeah.
It really, again, these situations and interactions, like you said, are going to be so individual that it is going to come up to your own, you know, personal judgment.
Mm-hmm.
And I don't want you guys to take one way or the other, because not everything fits and one size fits all, right?
Yeah.
But I do somewhat agree that, you know, sometimes knowing less, right? Giving less information in certain aspects, if you deem it to not be detrimental, right? You decide. As long as you're collaborating with said client and you guys both come to the agreement, right? That's what's most important.
Mhm. Yeah.
I just wanted
Thank
to
you.
make a little bit of space, if that's okay. Sorry,
Yeah.
Naomi, for Danielle. Sorry, Megan.
Hi, I just wanted to chime in and answer just some of that question. As we are planning our June follow-up for this, I'm actually in conversations with different attorneys that specialize in mental health, and I'll be bringing this question specifically to them about what the best ways we can word things and mitigate and still maybe meet some of those requirements. Like I know, for example, Virginia Mason wants us to specifically sometimes say language like, a complete biopsychosocial assessment was performed in ways that we can maybe honor the requirements so that people can get care, but still do that in a way that isn't introducing additional barriers. So I love that question. And I do think that's something that we're absolutely one of the main priorities for addressing from a legal and also an ethical aspect of like, there's different tensions and how do we hold those within, say, our social work codes.
Thank you, Danielle. So yes, you guys should stick tuned and come to the next one. But yeah, you're absolutely right. Like that is outside my realm, right? It all is individual and it's going to come up to, again, the collaboration between you and the client and coming up with what's the best solution, right, for them. Megan.
I really, it's hard to wrap my head around like this complex issue. And I obviously agree with reducing barriers as someone who's had one of these letters written for myself, but with the substance use issue, I think it is worth having a conversation with your client around the potential for needing to have the conversation with your surgeon if this is left off of your insurance letter or the letter to your surgeon around potential complications around some substances that are known to have interactions with the surgery, whether it be for anesthesia or known, like cannabis is known to cause nipple death, for example. So if you are to have that conversation where it's going to be left off the letter, that you talk to your client about being open with your surgeon around substance use. So I have to throw that caveat in there, please.
No, absolutely. And yes, you're absolutely right. There is contraindications in terms of like anesthesia and cannabis, right? So that's why you're absolutely right. The client should always, I shouldn't say should always, but hopefully they have a very open line of communication with their provider, right? And you're absolutely right. In respect to whatever you put in the letter, whether you put it in or you put it out, like you still should have that conversation, right? You shouldn't make that decision just on your own, because it does really come down to it's their health, right? It's their livelihood, it's their life. So in again, doing no harm, if you were to omit that from said, letter or not allowing yourself to explore that with them, you may be causing harm, right? You may be inadvertently potentially causing something to not go as well as it could be potentially in the future. So yeah. Thank you so much, Megan. You guys all have very great constructive input and questions. And I think that this just beckons us to recognize that not every situation is going to be the same, and every situation is going to present a different challenge for you to be able to overcome with your client. But with that being said, does anyone else have any questions, comments, or concerns? Yes, Anne.
So this is super random, and it sounds like a lot of us are therapists, and so maybe someone even remembers this post, but there's also, I don't know where we're all located, so maybe not, but I'm a part of a couple of Facebook groups for just like Greater Seattle, kind of Pierce County and surrounding area therapists. And recently there was a post where someone asked a question about a letter and someone else responded and was really adamant that like letter writing should no longer be like required or a thing. And it was kind of this big long kind of back and forth on the thread about whether it is actually like whether insurances are legally required to, or legally allowed to require the letter, or if it's more so just like a preference that we all sort of fall in line and follow with. And it was the first time that I had heard that like this might not be required anymore. And so I was really interested if there was anybody else who knew more about that. And then also, I was just wondering if anyone knows about how this, the Senate Bill 5313, the Gender Affirming Treatment Act, like how that impacts letter writing, because that, just went into effect a few months ago. And so I'm just curious, like what we know about that.
Absolutely. We actually, thank you for reminding me, that was exactly SB 5313 is the one that made it so insurance companies, specifically Medicare, Medicaid, that's generally what most RCWs and WACs are formulated towards, in which any cosmetic surgery, anything deemed cosmetic surgery, could no longer be denied by insurance companies. So as it stands, people still do need letters for gender affirming surgeries in terms of top, well, not top, I should say, yes, top and bottom. Sorry, it's late. I've been up since 4 for top and bottom. But for anything else, cosmetic wise, they wouldn't need a letter. Some insurance companies required letters for feminization or emasculation because of the fact that said individual might want it to be covered by insurance, right? But that is no longer an issue because of 5313. So anything that has to do in terms of like top or bottom surgery, you letters are still required.
Thank you. It was an interesting thread.
Yes. It's really easy to misunderstand legislative wording, right? It's like its own language. So yes.
Okay, so I am going to let Leiyomi off the hook for the rest of our evening. She just, came off of a 10-hour shift, and thank you so much, Leiyomi. Can't thank you enough for sharing what you've done tonight, and I'm really looking forward to part 2. And yeah, stay tuned. Thank you all for coming.
Awesome, rock stars.
Yeah, thank you, Leiyomi.
And then there were 8. Have a good night, y'all.
Yeah, exactly.